The country's Minister of Health, Dr. Austin Demby. The minister is here to talk about the country's healthcare system, ways to improve it, successes and challenges. Good morning. Thank you for joining us.
Good morning, Fabian, and good morning to your viewers.
Good morning.
You've had, the opportunity of staying longer in office, even with the reshuffling that's been going on. You've conveniently secured your spot as Minister of Health and Sanitation. What progress have you made in the healthcare system?
First off, I want to be grateful to His Excellency the President for granting me the opportunity to continue to serve. We don't take it lightly, because there are about 8.5 million of us, and so if one person is picked to do a particular job, it's an honor and it's also a privilege. I think one of the things in the healthcare system that we need everybody to understand is that we're radically changing the way healthcare is delivered in this country. For the past 20, 40 years, there's been a deliberate focus on diseases. So you have a malaria program, a TB program, an HIV program, a nutrition program. And so one of the things that I am focusing on, I don't want to have the best malaria program and somebody dies of typhoid or somebody dies at childbirth. In that case, we're all lost. So we're shifting the focus from a disease-specific to a person-centered care. We're looking at the person. We're looking at a 360 around the person. So when this person presents in the hospital, we want to see all aspects of their health. And so you can imagine an institution that's been built one way and you're trying to shift it the other way. But it's very profound. We've made tremendous progress. And I think what we want to do is to have all 8.5 million of us see ourselves in the healthcare system, and the healthcare system sees everybody. And that's what we're calling universal health coverage. And the best way to do that is to follow the life stages. What that means is we look at the pregnant woman and just say all of the 300,000 to 400,000 pregnant women, how do we provide services for them so that they remain healthy and they deliver safely? And so we set targets, we work towards those targets. And when the baby is born, we say, you baby, you're here now, you're a new citizen. From age 0 to age 6, what kinds of services do we provide for this baby to ensure the baby doesn't only survive, but the baby thrives? In preschool, how do you make sure that this baby is ready for school? When the kid is in school, the kid is focusing on learning. How do you make sure their health needs, their hearing, their eye, their malaria, their TB, all of that is taken care of to let them focus on their education till they become teenagers and they become young adults and senior citizens. So we're following the whole life course approach, and we're looking at in each stage to see what interventions we take and set targets. The cool thing is setting targets. We're beginning to see the results. For example, just looking at pregnancy, we've been able to dramatically reduce maternal mortality in this country. It's not only reducing maternal mortality, but improving maternal health, such that we're the fastest drop in maternal mortality in the whole continent. Even as we speak, we're expecting some visitors from Burkina Faso and from Botswana in the month of November to come and see how we did it. For young babies, for young, we focus and say, look, we're going to reduce childhood death, infant deaths dramatically. And so what that means is we ensure that there is zero child that hasn't been vaccinated. Zero those children, we bring it down to zero. Make sure all of the children have their vaccinations in the right regimen. Make sure the nutrition is taken care of. Make sure the malaria is prevented by making sure that the bed nets are available, insecticide bed nets are available, and malaria vaccine is available, and ensure that we have rapid diagnosis and treatment. And the same thing for young adults. We're looking at the HIV rates in the country and to see how do we better manage HIV infection and prevent it such that we're able to reduce the deaths associated with it. And for people who are infected, ensure that they have the right medications and they're able to carry on their treatment and live a normal life. The same with TB. We ensure that with TB, 80% of all of the TB cases have an underlying HIV situation. So we don't want to separate them, we want to deal with them both at the same time. As we're doing all of these things, the human resource is very critical, and so we're looking at training more doctors, training more nurses, and it's not just basic training now. We're looking at postgraduate training to bring specialists in. I mean, just a few weeks ago, we graduated the first 8 OBGYN surgeons who were trained here in Sierra Leone in their postgraduate training. Now they're members of the West African College of Surgeons. So that's going on. The nurses are training, the community healthcare workers are training, and I think we're really beginning to show changes. It's not right away, but you begin to see the changes, the shift in focus.
Before we delve deeper on into some of the issues, let's get to understand, in the previous administration of President Ernest Bai Koroma, he had made a priority. As we speak, what's the current status of that free healthcare program? Because there were countries that were also supporting us with the medicines. What's the status of that free healthcare?
Free healthcare is alive and well. The free healthcare, the previous administration started it, and we've expanded it. We've expanded it because now the free healthcare is for all pregnant and lactating mothers. It is for Ebola survivors. It's for the most vulnerable people. It's for handicapped people. And so it's broadened the scope a whole lot more. The partners are still with us, but the arrangement was the partners will slowly wean themselves off as the government takes greater responsibility. The problem with free healthcare is it's directed at a small group of people, the most vulnerable, pregnant women, lactating mothers, children. But I think what we're worried about is, what about everybody else that does not qualify for free health care? So what we're doing now is to try to actively launch an insurance scheme, a health insurance scheme, that will allow people to pay a small premium and be able to pull the risk. It's not everybody that breaks their leg. It's not everybody that has malaria on the same day. But if we all pull a small amount of money for ourselves, we will be able to make sure that if one of us gets sick, we're able to use those resources for it. So the free healthcare is alive and well. We've expanded the scope. We're trying to complement it now for those that don't qualify. So fairly soon we will be launching the health insurance scheme. But we want to launch the health insurance scheme as part of a broader approach. We want to have universal health coverage. Universal health coverage means health for everybody. So if you have a small group of people who are covered by free health care, we want to have the other group, the other complementary group that's covered by a health insurance scheme with minimum premium associated. When you combine these two, that is the approach we're taking to universal health care.
The transition from a disease-centered to that of a people-centered makes a lot of sense. But again, taking into account, this is a sector that has been budgeted for about 6 to 7% of the country's budget allocation. And this comes in with a lot of shortcomings within the health sector. Taking into account, many will say it seems very much underfunded. How is that impacting health outcomes for particularly the country?
Well, I think we all had the Abuja Declaration, where all the countries in Africa agreed to have like 15% of their budget allocated to health. And so a lot of countries have been working towards that. I think for us in Sierra Leone, we're aggressively moving towards the Abuja Declaration. I think at last we were like at 11% or so, which is much higher than a lot of countries. But I think having said that, when you look at the economy of the country, you're looking at 11% of what? We're in a very, very difficult financial state, so the 11% is we're very pleased with it, but it's a small amount of money, compared to the need that we have. So what we're doing is, as we try to slowly increase the amount of resources that's going to health, we're looking to work with our development partners to help us bridge this gap. So, for example, at the last budget iteration, the operational cost for the Ministry of Health was about $50 million or so, so for 8.5 million people. But so we had to go raise another $300 million from our friends, our colleagues. So I think we just getting the balance right. We always need more money. We always need more resources to be able to provide the kind of health care we deserve in Sierra Leone. But in difficult financial times, we want to make sure that there's value for money. Every dollar that's invested, every Leone that's invested in healthcare, we want to make sure that Sierra Leoneans derive the best value for it.
Over time, we've seen many partners who've come in to, of course, help capacitate the health sector, of course, make things better. One of which is that of PIH. We've seen them supporting 6 districts over time. But again, let's have a holistic look on the health sector, particularly so for those in vulnerable communities, say provincial areas. The facilities could be one, and access to those facilities, adequate facilities is another thing. Is the ministry still concerned with the problems those communities continue to face?
I think you're very right. You know, when we say universal health coverage, it means health for everybody. You know, you have to be able to make allowances. It's not just people in Freetown or in the urban areas in Bowen, Kenema, and McKinney. You want to look at people all over the country. Now, I just want to remind all Sierra Leoneans, we were the ones that actually read the Alma Ata Declaration in the world that set primary health care as the most important way of delivering healthcare services. What that means is taking healthcare as close to the people as possible. In Sierra Leone, for the past 40 years, we've invested very, very heavily in taking healthcare as close to the people as possible, such that for 85% of the population, you have a health facility within a 5-kilometer radius. That is progress. That is higher than most countries in the continent. What we're focusing on now is how do you bring quality to that access? So we're looking at 4 domains of quality. One is infrastructure. Physical infrastructure. You have to have a building that somebody will want to go to. It's clean, it's safe, it's got energy requirements, it's got, now we're transitioning from all of these generators into solar energy and ensure that there's water available there. That's physical infrastructure. We're looking at personnel and ensuring that you have the right number and the right mix of personnel in these facilities. The third is equipment, ensuring that the right equipment is there and the supplies associated with it, and drugs. So with those 4 elements of quality, what we're looking at now is of the, I think it's about 1,600 facilities in the country. We're looking at each and every one of them to see if they meet those quality requirements. And our role now is to expand those and make sure that those quality requirements are met. We want by 2030 to increase it from 1,600 to 2,000 facilities. Now what we're doing is all of these new facilities, you're not going to see a generator there at all. We're going to ensure that they have solar panels and ensure that the water and the energy requirements are met in those facilities.
But again, even as we talk of the transition to clean energy in the hospitals, it's very clear, and you're also aware of the fact that governments seem not to be taking the lead in furnishing most of the facilities they have. Take, for instance, Connaught. As we speak, it has no functional CT scan, Dr. Demby.
Well,
it's making the situation much more worrying towards these government hospitals.
I take your point, but have you been to Connaught lately?
I've been to Connaught.
I think you should. Maybe next time you and I should go in there. It's transformed. It's transformed radically from the outpatient department into the actual wards themselves, into the specialty units, the stroke unit, into the children's unit, into the surgical theaters. We're building the burns unit there. You have the doctor's hostel in there. It is transformed. Right now, they have oxygen factory in Connaught that pumps oxygen directly into the ICU, the only true functional ICU in the country. All of the top doctors.
You said true functional ICU in the country?
The true functional ICU, the most important one. I mean, they have other ICUs. Choitrams has, a few of the others have. But if you really want to have a truly functional ICU, Connaught is your place. So I get the point that we need to upgrade, we need to uplift things. But I think let's recognize what has happened so far. What we're trying to do, again, for your listeners, for the past 40 years, we've focused on primary healthcare, as I indicated before, which is really great, which is more taking healthcare to the people. What we hadn't invested enough in is secondary and tertiary care, the bigger hospitals, because quite frankly, everybody's worried, how do I put money into expensive doctor training, expensive hospitals? What we've been doing now is to rebalance, double down on primary healthcare and bringing quality to it, and invest in hospitals now as well as a complement. So you don't want failures in primary healthcare and you don't have a landing zone in the secondary and tertiary facilities. So as you could see that there's major activities going on now to build up the secondary and tertiary facilities. Connaught is paramount. PCMH, I just went there and we opened a new outpatient department and a new pharmacy bought there. You have the new children's hospital at Lumley that we're building. We just got $50 million to build a brand new state-of-the-art hospital at Carytown. We're working on a $100 million hospital in the center of the country between Bow and Kenema. As you said, with PIH, we are working on the Connaught Hospital to be open in the next few months. So there's a lot going on as we speak. Now I'm going to break ground on a new hospital in Moyamba, Pujong, and Karine. There's a lot going on in the hospital sector as we complement what's going on in primary health care. I think when we started out, I told you that we're focusing on patient-centered care. What I want us to do is to not be distracted by flash in the pan, the big flashy things. When we build a hospital, we want it to be truly functional. When I mean functional, it has the equipment, it has the supplies, it has the personnel, it has the expertise, it has patients at the center, at the core of the activities. That's what we're doing.
Dr. Demby, let's talk about doctoring the doctors.
Yes.
A few days ago, we had the Secretary General in the studio talking about their strike. The thing is, the doctors work under such strenuous circumstances, from inadequate water supply, electricity supply, even supply of medication for those supposing to be benefiting from the free health care. Long duty calls. They complain some of the hours are crazy long without even a provision of food supply. No increment of salaries for almost about 15 years. This is affecting their mental health. And these are the people who are supposed to be performing surgeries, supposed to be diagnosing whatever is wrong with people, treating them. How do you doctor people when you yourself, you're not in the right mental frame?
Fabian, that's a very important issue you raised. You know, again, as I was saying, the hospital is not a building. The hospital, it's its function, you know, what happens in there. And the doctors are central, they're critical to this work that we do for patient care. Their well-being, their welfare is vitally important to this government. To start with, most of the doctors, nearly 100% of the doctors, all of their fees are paid by government of Sierra Leone, by your taxpayer money, to get their training, including postgraduate training. When they go out overseas for training, we ensure that the scholarships are not given to individuals. They're given to the country, and the understanding is they'll go and train and come back to the country to support it. Yeah. At the same time, as I was saying, it's really important to look at the 360 around doctors. First, you need to look at what is needed. For 8 million people, we need about 5,000 doctors. We only have about 500, 600 doctors truly functional. So there's a huge deficit there. So we need to be able to forecast the need and train towards that need. As you train towards that need, make sure that you bring in all of the new skills, the new technologies, the new things that will make them truly functional. As they train, you want to deploy them.
How do you bring that in when those who are currently in the field don't see it maybe viable. The Secretary General spoke about a survey they did. Just a minute, Dr. Demby.
Yeah.
He spoke about a survey they did, and part of that survey, only 20% of the doctors we have are willing to stay home and serve.
Yeah. Can I land? Okay, I said you forecast the need, you train towards the need, you deploy based on the need, and you focus on retention. So that's the piece that I was coming to, on retention. Retention has a lot of issues that will let people stay. We've trained about 1,500 doctors over the past 30 years. Only 500 of them are here. The rest have gone. So what we need to do is to be able to figure out a way to retain these people. It comes in compensation, and we're looking at that. It comes in with privileges, we're looking at that. It also involves giving them the tools to be able to perform their trade and ensuring that you could stay here and be actively involved in impacting the health of your people, but also be globally relevant by being involved in active research. So what we're looking at is to say these young people, after their training, in the past you have to go to Ghana or to go to UK or where, for your postgraduate training. Now we're offering postgraduate training here in country. You know, and as you're doing your postgraduate training, there are opportunities to be actively involved with an R1 grant or an NIH grant, you know, where you could have phenomenal resources made available to you that will help you with your patient care as well as your remuneration. So we're looking at creative ideas to ensure we retain these staff. Yeah, again, we all think that we're a very, very wealthy nation. I think that's correct. That's very true. We're a very, very wealthy nation. But we're going through a difficult financial crunch as a nation. So when you have these difficulties, the hurt is spread all around, and we try to soften that for healthcare workers. So, I mean, in a lot of places you sign a contract that after your training, and the government pays for your training, you serve them for 5 years or 6 years or 7 years, you know. We don't have that, you know, and people are doing it because they feel that they have a duty to help the community. So again, we have to meet halfway and support them and make life easier for them and make opportunities available to them, even as they serve. You could go to Ghana and make more money. You could go to UK and make more money. You could go to the US and make more money. Yeah? But if the people of Sierra Leone paid for all of your education, and then you go and benefit Ghana, and benefit the UK and benefit the US, is that fair to Sierra Leone?
But it also concerns them that when they go for trainings or so, they perform better than even their counterparts in Ghana. Academically, they perform better.
We're so proud.
Yet we still have our people choosing to go to Ghana in trust, in confidence that they would offer better services and facilities, trusting that their lives could be safer in the hands of the Ghanaian doctors in Ghana than our doctors in Sierra Leone. Why is that so?
This is really, really important. It is building confidence in the Sierra Leoneans to utilize their own services. You go to Ghana, you go to all of these, you go to the UK, and you go to Birmingham. There's Sierra Leonean doctors. You go to Maryland in the UK, in the US. There's Sierra Leonean doctors who are thriving, who are doing extremely well. Yeah, and some of them are here. Yet, you know, you go to Ghana, and the Ghana doctors are saying, "Why are you here when you have the top cardiologist, Dr. Russell, in Freetown?" Yeah. So what we want to do is to do two things. First, build the institutions. You know, build the Connaught of the future. You know, just go away from that history of 3 years ago. When I was here 3 years ago, people were throwing dirt at Connaught. Go and change that reputation, that track record. If I am sick, I'd rather go to Connaught than to go anywhere else. So we need to rebuild the confidence. We need to rebuild the doctors. We have specialty training now for OBGYN, for pediatric services, for psychiatry. You know, here in Sierra Leone, we're only training Sierra Leoneans. We're going to be bringing people from other countries to come and train here. So again, I think we need to have confidence, because I don't blame somebody who wants to go overseas for their care. It's because they don't trust the system here, even though empirically it's better than where they're going to. So we want to build a system here. We want to build trust here. We want to make sure that we use these services here ourselves. And we're expanding it. I just bought, I'm in the process of buying 2 CT scans from a friend of ours who just gave us the money for it. We'll put one in Connaught as a public hospital, and I'll take one to Kenema. And we'll raise some more money to have CT scans in all of these facilities. We want imaging, we want diagnosis, we want critical care. I'll tell you something. You remember there was a story with that young guy who had his tibia broken, snapped, and he was hovering around for a whole year, and it was an internet sensation. That kid was identified. It took him to all of these places. They said, amputate the leg. We were told, if you don't amputate, this kid is going to die in about 48 hours. I said, let me get a second opinion. We got a Sierra Leonean surgeon and looked at it and says, I've seen this before. It's incredible. This guy is the bravest kid I've ever seen, because there are 2 bones in the leg. One is the smaller bone, one is the bigger bone. The bigger bone is the one that snapped. And since he's been hobbling around, he's built strength in the smaller bone. And the doctor said, we're not going to cut this leg, we're going to salvage it. He was able to repair that leg, and to the chagrin, to the shame of all of these other experts who were saying, cut the leg, the kid is roaming around happily. So we have good doctors here, we have good surgeons here, we have good people. All we need now is to increase the facilities for them. I don't know if you've been to the new pediatric facility over at Lumley. Please, you should go there. When I walked in there, I nearly wept. Because this is what you see in Europe, this is what you see in America, this is what you see in Australia, in terms of facilities, in terms of equipment, in terms of space. That's what we're trying to build.
Dr. Demby.
Yes, sir.
With the current unfolding of things, see, for the past 15 years in Sierra Leone, it tells you we have people who are faced with a lot of mental health problems in the country. But the other day we had Dr. Jallo, who is the lead psychiatrist in the country, who says they are still challenged in terms of operations and activities. And again, as a country, it seems more like we have only 1 psychiatric hospital. Say for those in other parts of the country, Kenema, McKinney, so to speak, they seem left behind in that regard.
I think this is one area in healthcare delivery that we haven't given the focus that it deserves. You know, I think mental health is, again, it's critical. Health. Mental health is a major component of health, and if you don't have that, you really don't have health. Unfortunately, we've focused a lot on infectious diseases and clinical medicine, and we haven't focused on mental health enough. So it's not right that we have just 1 psychiatric hospital in the country. Over and beyond that, mental health is not just what you see as the psychiatric cases. Mental health is a continuum. And we have to be able to deal with this continuum, from stress management, from managing simple issues around agitation, around management, around social interaction, to ensure that you don't graduate to where you need psychiatric help. I mean, how do you manage trauma? We're here with Ebola, and hundreds of people, thousands of people died. We're here with COVID, people dying. We're here with mudslide, people dying. As a nation, we had 11 years of war as a nation. Everybody is traumatized. I mean, people don't even know how to talk to each other. Na Allah in the Allah. Also, you want to talk na Allah in the Allah, you know. Again, it's a result of some deep-seated stress that we haven't managed. So I think for us, we're looking at how do we look at mental health as a spectrum of care. How do we look at mental health not only as Kisi Psychiatric Hospital, but how do we look at mental health in school children? How do we look at mental health in pregnant women? How do we look at mental health in teenagers? How do we manage that within institutions and outside of institutions? How do we have counseling? So making very, very close partnership with the Ministry of Social Welfare in Children's Affairs, and to see how we could work together to deal with some of the preventive components of mental health before you need clinical care. I think the President has established a new secretariat with the VP chairing the secretariat that looks at mental health in its entirety. Again, it's not just Ministry of Health issue. It's a lot of groups, women's health, youth health, social welfare, law enforcement, everybody actively involved in looking at mental health.
We've had a number of messages on our Facebook.
Just before we get to those, Dr. Demby, you've painted a picture of hope for the people in the ability of our doctors and the upgrade, so to speak, going on with the hospitals. You are the country's Minister of Health. Yeah. Which hospital do you go to when you fall sick?
Okay, my number one is to go to Connaught. Unfortunately, I try not to, because you go in there, they want to treat you special, and I don't want to be treated special. I want to be treated as everybody else. And I have doctor friends who take good care of me. I had an incident here where I collapsed at one point. I had doctors at Connaught and doctors at Choitrams. They took care of me. I took all of the records and sent it to the U.S., and all of the doctors in the U.S. confirmed that it was very good diagnosis, it was very good care, it was excellent care. I was very thrilled to know that we have those capabilities here. What is missing is the confidence in all of us to know that we have these available. And we have Dr. Kapua, who is the medical care manager over at Connaught. He is dealing with incredible things every day. When paramount chiefs or elders are sick, that's where we send them. We're trying to ensure that we could get the annex fixed up properly. We make sure that we could expand the ICU, make sure that we could expand the outpatient department. Again, just to cut it short, Fabian, I will use the services here anytime. And I will encourage all of us to do. Again, what we're also looking at, we want to have a balanced approach to it. We don't want to make sure that health is reduced to the least common denominator. The government services in the public sector is a safety net. We're looking at working with private sector, encouraging private sector to come in and complement the service delivery. For example, you have Choitrams, you have multiple private institutions that are coming up. We encourage them. We encourage them so that in a lot of cases when people pay to go overseas, you're not really paying for the medical. The cost driver is not the actual medical care. It's the transportation. You fly out and you have somebody fly with you. You go stay in a hotel for several weeks or so and then fly back again. Whereas if you get rid of those costs, the actual medical costs will be not as high. So, for example, as a government, we've decided that we're not going to have, we're not going to encourage international medical travel. Again, only in an emergency or in special sympathetic cases. What we want is, we've been spending about $3 million to send people overseas for care.
For the entire country or just for public government workers?
Overseas?
Yes.
For the entire country, But what we're trying to do now is to reduce that, considerably and invest it in postgraduate training, in building the facilities.
Dr. Demby, that's a brilliant idea, but how would it work when, even with the confidence you're trying to instill in the people to utilize the public hospitals, our president travels for medical checkups in other countries?
Well, again, I mean, I can't speak for the president, but I mean, he has local physicians that take care of him here. I mean, so again, he doesn't go to Connaught because it'll cause a stampede if he's in there. He doesn't go to Oladurin, but the doctors will here take care of him and his family. So I don't, I mean, it's not your routine services that you just go out overseas for. I mean, if there's a special need for, you could go overseas. I mean, anybody could go overseas for special needs. But for routine services here, we're all using, our doctors are top notch, Our doctors are top-notch, and I think we should give them credit here. Again, one of the things that I tell everybody about, we're smart. I don't want it to be arrogant, but we're very, very smart. Even people who fail their exams here, when they go overseas, they top their classes.
Right.
Yeah. So again, for me, what that means is you've got talents, you've got aptitude, you've got capabilities here. Let us create an environment where we could tap into it. We could utilize it more.
Aside from the public officials that Fabian just mentioned, over time we've seen rare cases, particularly so for kids, say those whom the Sick Picking Project looks after. Are you concerned, Dr. Demby?
We're very, very concerned
with those cases, because it's becoming worrying. It could be someone's kid at one time. It could be even your kid.
Yes. We're very, very worried about that. In fact, yesterday or 2 days ago, somebody sent me a picture of a kid from Kabbalah that had an eye issue. You know. Again, when we're building trust in the system, you know, but if you don't trust the system, you know, it becomes a problem. I don't blame people. We blame ourselves. Let's bring trust in the system. This kid had an eye issue, and they kept putting native medicine in there and all kinds of things, till the thing is worse now.
It's because of poverty.
It's not poverty. It's not poverty, because when you go to the witch doctor, the native doctor, you pay a fee. Here you have free service for children.
Not as expensive as the formal services.
Well, you see, that's the impression that's given. But the reality is that it's free service for kids. You show up there, and no, in practice, you show up, because what's happened now, there's this reputation. Again, what I'm doing here is to rebrand the Ministry of Health, rebrand our healthcare. But there's this bad reputation that you go in there, it's a shakedown, they take everything out of you. So again, simple thing like this.
But that's the reality, Dr. Demby.
I get worried.
Not long ago, AYV personally, we had one of the nights after work, an accident with someone riding a bike, and that person turned out to even be a police officer working at the CID. Upon arriving at the King Aman Road Public Hospital, the emergency section, could you believe they refused to administer any form of treatment or attention to the patient until money was paid. Even when we got there to say AYV would foot the bills. They didn't touch that man. They were going up and down, up until we figured out to send mobile money to them before they attended to the patient in an emergency situation of accident.
I think that's completely unacceptable.
That's not even up to 4 months ago. It's within the last 2 months.
It is completely unacceptable. It's completely unacceptable. In emergency situations, we have to be able to allow and make room for that. Somebody's not going to have a broken leg or so. You say, I can't treat you until you pay.
And the patient was bleeding. They didn't even care to check.
So I think that's completely unacceptable. But bear with me, as I indicated.
But that was to point that all the work you do to rebrand, in theory, it only comes back to boost confidence to the public if those who go to test the system come back with positive testimonies.
But you see, the important thing about this is that out of the 99 went there and had a really good experience, but they told no one. The one that had a bad experience is what we amplify. You know, every day you go to the hospital. Again, when I go visit the hospitals, I have 2 visits. I visit the technical staff, professional staff, to see how they're doing, how do we help them, and then I ask the public what their perception is. I mean, I'll give you an example. For me, it's more than gold. I went to Maburuka Hospital. I was there visiting with folks, and the paramount chief from Maburuka came to the hospital with his friends to introduce them to the hospital. He's proudly showing off the cleanest hospital in the country. You know, the public toilets. I went in there, I wanted to use the bathroom, and they said, the bathroom is over there. It was the cleanest bathroom I've ever seen in Sierra Leone. So again, this is going on. People are sharing good experiences in these facilities, we need to amplify those. The bad ones we need to identify and fix.
Human reality is bad news spreads wider than wildfire.
That's right.
Do you see the need as Minister of Health and Sanitation to probably seek help from perhaps the Anti-Corruption Commission's Scorpion Squad? They do good work with the education sector, but in the healthcare system, there are a lot of allegations.
I would just say,
if you ask for medications that are supposed to be on the shelf and free to patients, it's unavailable. But when you go to buy, especially the nurses, suddenly they have it to
available.
sell, but it's unavailable on the shelf. Do you see the need to seek help from the Scorpion Squad of the ACC?
I see an absolute need, and I'll just say, watch the space.
So you were talking on. You were talking on.
I don't want to go public about the plans, but just watch the space.
Dr. Demby, you were talking on the situation that kids in the country face, mostly in terms of their elements. When Phoebe asked that question.
Say again.
The current situation of kids who are faced with, these rare situations.
So I'll tell you something. Let's just be realistic. The per capita health expenditure here, when you say everybody in Sierra Leone, let's share the money. It's $46 per capita for everybody. Everybody is entitled to $46. That's why we buy drugs with, that's why we pay doctor's salary, that's why we do everything, To send one person overseas, it's about $22,000. It's the equivalent of 400 people not having health care for a whole year. So it's very challenging. We could take one of these kids who are in a very, very difficult situation and provide health service for them, high-end health service, but then it'll be at the expense of everybody else. So what we try to do is to ensure we provide good quality and work with partners like the Mama Peking Foundation, like the Children's Foundation, like Adonis Aboud's Foundation, like humanitarian efforts that could help us with these exceptional cases. And in a lot of cases we partner with them to support them. But again, this is the reality of it. As we build these institutions, for example, with these kids that are suffering now, that's why we have Lumley, the new Lumley Hospital. It's got 2 oncology wings. It's got 2 oncology surgical theaters. It's got Dr. Bell in there, one of the top surgeons around here. Again, we're building up that capacity so kids like these don't have to go overseas. For example, with this one kid that I saw that I told you that they had all of this, Dr. Jalikat Mustafa, who is an eye surgeon, who's doubling as Deputy Minister of Health too, she's allowed to do surgeries and practice every Friday, And so she sees all of these complex cases that you're talking about. She just did a couple of corneal transplants this weekend. So there's a lot going on. So for these special cases, we'll look to see how much government could do, but we're also looking for philanthropic humanitarian organizations that could complement what government could do. Because if government were to take on all of these complex cases, we wouldn't have enough money to serve everybody else.
Now let's turn the mic to our viewers who following us from across our Facebook page. First, from my end, is from Sir Koninga Mustafa Kokowai, who says, those are healthcare workers aware that emergency cases are treated before asking for money. What is defined as emergency, and do they know what it is?
Osfran Kamara says the surgical wards at the tertiary hospital form because of its location. Upstairs is no ramps or lifts to transport patients from the surgical theatres to the wards. When elites look and fail to see people's needs, it can be devastating. Reform, reshape. To look in different from seeing care pathways entails resourcefulness to deliver.
Sir Bandabla says, Doc, we still have healthcare facilities who that don't have common gloves. Patients or their caretakers are asked to buy simple gloves before treatments will commence.
Sise Ali says, Mr. Minister, then, I just want to know, I just want you to tell, to elaborate the issue being raised by the doctors. In other words, their fuel entitlement.
This one says, he says, please, the attitude of healthcare workers is very appalling. The value money more than life of their fellow citizens. Salomon gets by that.
Osfran Kamara again says, Dr. Demby, is there any update regarding the money given to UNICEF for the procurement of pediatric equipment during the tenure of your predecessor?
Mosdi says the issues are not about our doctors and their capabilities. Leone has long since been acknowledged for producing brilliant doctors, probably one of the best in Africa. It's the lack of proper facilities, equipment, services, and in most cases, the effective medicines.
Abubakar Rashid says the problem of this nation is that we don't value good people and professionals. We don't motivate and then bring in people and place on top of them after serving years in a position. So frustrating for someone who has worked hard. So we continue to go in a vicious cycle. Those who cannot bear with the situation go away to better environments.
Swissman says, if we're talking about medical, why not talk about constant electricity in every hospital in the country? There are people who die in oxygen because of poor electricity in hospital.
Osfran Kamara says there were some technical issues with the biometric registration system installed at the main entrance of Connaught Hospital for the registration of health workers. Has it been fixed?
Continue, Fabian.
Mosdi says, with all due respect, sir, are you saying the people, that is doctors, nurses, and even the patients that are seeking treatment from these facilities are not honest in their deliberations? Reports after reports have suggested anything but what you're telling us, sir.
James Masakoi says, Dr. Demby, any updates on the Carytown facility?
Mosdi is saying the issues are not about our doctors and their capabilities. Sierra Leone has long since been acknowledged for producing brilliant doctors, probably one of the best in Africa. It's the lack of proper facilities, equipment, services, and in most cases, the effective medicine.
Mystic Doazak says the medical doctors are essential in the day-to-day running of our healthcare sector. Your ministry, in collaboration with the Ministry of Health, should do the needful by ensuring that medical doctors get their entitlements so that their actions will not tell on the ordinary Sierra Leoneans.
Sir Bandabla says, my question now is government supplying these consumables to healthcare facilities?
Mystic also says, good to hear from your studio guest in the area of universal health coverage. We're still faced with challenges as a nation because accessing healthcare center is still a challenge, especially for the people of Sandama Bolonso Chiefdom.
Doc, there are tons of messages. I think we'll take them in bits. So we'll get you to respond to this and we'll probably take another set.
Okay, all right. I think one of the things to just remind everybody that health is a top priority for this government, and the President and the Vice President and Chief Minister. They have instructed the Ministry of Finance that the allocations for health care take precedence over everything else after salaries. So when they pay everybody else's salaries, healthcare institutions are first in line. They call it life-saving allocation. You know, to build a bridge, you could delay it for a week, you could delay it for a month. To have a construction project, but when it's life, you need the funds right away. So starting this year, you know, the VP called a meeting with the Minister of Finance, and we all agreed that life-saving allocations come first in line. So with regard to the fuel allocations for the doctors, the fuel allocation is a mandatory requirement. It's something that's a part of their package. It's not just for doctors. All healthcare workers, all government employees at grade 9 and above are eligible for fuel. And so what has happened is that this fuel is allocated as a routine to all services. But when you have a very difficult financial situation under which we're going, the priority is to pay salaries first. And then you could look to just see what other opportunities arise, including the fuel. So the doctors have been giving their first quarter and second quarter fuel. So January, February, March, April, May, June, been paid. What's left now is July, August, September, October, November, December. What we're working on now is to ensure that we pay for the whole year. And so the Minister of Finance, as we speak, they're drawing up the checks to ensure that these bills are paid for the whole year. What we also talked about is to ensure that for the future, that the doctors don't have to wait. Let's look at a system that will allow us to ensure that they get their fuel on a regular basis. Now, the issue of strike, no strike, I think it's very troubling in a way, because the doctors are civil servants. You know, the doctors, the SLMDA is not a union, and so you don't have collective bargaining authority, you don't have collective bargaining rights, you don't have collective bargaining certificate. Again, I understand, and I'm very, very selfish when it comes to health matters for my health workers, but I'm also empathetic with the Ministry of Finance. What you have is daily resources to satisfy immediate needs. That's what is going. Hand to mouth, hand to mouth. That's the feeling I have. As soon as you finish talking about the doctors and the health workers, the nurses are there, they want their own as well. As soon as you finish talking about that, the children, if you don't pay the WAS fees today, nobody's going to take their exams. The next thing, the children, if you don't feed them, so the Ministry of is, and the agriculture comes in, if we don't get the seeds today, we're going to miss the whole year. So the Ministry of Finance is under tremendous stress. So even though I'm selfishly looking at just the healthcare, I want everybody to understand how much stress and how much bargaining that the Ministry of Finance is going through. And you know what? Health, we trust the doctors, we respect the doctors, we honor the doctors. But this is a service, a sacrifice that you're making for your people. It's not the kind of thing, because they could always make better money elsewhere. But the fact that they're here, they're sacrificing for their people. And if you leave today, who's going to make it for us? Who's going to do it for us? So again, I think we're not yelling, we're not screaming. What we're looking for is for an understanding with our doctors. Let's work together, because what we want is to make sure you have your fuel in good time to move forward. Now, there's 600 doctors. There's maybe another 1,000 other healthcare workers that are eligible for this that haven't received their first quarter yet. So this is the dynamics that we're dealing with. I mean, there's several other issues, yes, like the attitude of the healthcare workers. Again, you could have the best hospital, best equipment, the best everything, you know, the best doctors, but you evaluate the doctor by the patient perception. So we want to acknowledge and say thanks to all of our brilliant, brilliant healthcare workers. But you're right, there are some healthcare workers that look at this as a power trove, and they shake down clients, they shake down patients. They're the minority. And I think what we're looking at the health profession is, don't allow some of these people to bring us down. You know, if you're giving a bad reputation, let's identify them and deal with them and remove them from the system, and let us encourage and work with those that are giving us the best. The Connaught Hospital upstairs is something we're working on, the surgical theaters. Again, as you know, this hospital was built over 100 years ago. You know, it's built for a small population. You could make all kinds of adjustments to it, but the real answer is to get bigger and better and much more advanced facilities. That's why we're going to Carytown. That's why we're going to Kenema. That's why we're looking at all of these regional hospitals. That's why we're also looking at a network of polyclinics around Freetown to help ambulatory care. So you could go in and get your little stitch, you could go in and get your malaria treatment, so you don't have to go to Connaught all the time and congest the space. So we want to decongest the big hospitals and build more polyclinics around them. So that's ongoing. We want to figure out a way to motivate our staff. On the issue of energy, I am so proud because we went to Dubai at the climate conference, and we declared that in Sierra Leone we're going to go green for health. And that means all our health facilities in this country between now and 2030 are going to go completely green. What do we mean by that? Right now, with those diesel generators, they just don't pump whatever toxic gases in there. It costs at times 20% of the hospital's budget to run the generators. And you have to go find fuel and fight with everybody else for fuel. So in the interim, we're having these connections with the main grid, but what we're looking at is solar solutions. Solar solutions that will ensure that all of the hospitals, all of the facilities have solar energy. Right now we have about 11 hospitals that are on track. We have an additional 18, we have 18 on track. We have an additional 11. We have 200 primary health care facilities that we're looking to provide solar energy for. And the solar energy is not just for light. It is for us to use the equipment in there, but we're also using it to run the boreholes that will pump water into these facilities. We're looking to ensure that all of the incandescent, like tungsten lights, are all removed in there. We replace them with LED lights. We're looking at ambulance services that are looking at solar hybrid ambulances. We're looking at motorcycle ambulances that are solar driven. We're looking at planting trees in all of our health facilities to ensure you have good oxygen and you have the space for the facility as well. So there's a lot going on in us getting green. Carytown, as I indicated, we've stalled a lot. We're working with the Ministry of Finance to help us with the perimeter fence around Carytown because we're constantly fighting with folks who are trying to claim the land. What we want to do is to have a new hospital, the 200-bed hospital that the Saudis are funding for us. We also have the Cancer Diagnostic and Treatment Center that's going to be there. We're also looking at ophthalmic care services. We're just closing the deal with the Global Fund and our partners to build a 10,000 square meter pharma-grade warehouse. So we don't have this the funny rice storage facility that we use to store our medicines, to have a real pharma-grade warehouse. So that's going to be a medical campus. And by the end of this, or by the middle of this dry season, you're going to be seeing a lot of cranes, a lot of action in that space to bring it up.
Just clarity, Dr. Demby, has the ministry received its fourth quarter subsidy as we speak?
Well, no. We're in the fourth quarter.
Sure.
And usually what happens is you turn in your receipts and they look at who's eligible and things to get it paid. With the doctor situation, we're just trying to offset the concern that you raised. That's why we want to even pay in advance for the fourth quarter. But as we speak, they're writing the checks. We hope that by the middle of this week, they'll receive both their third and fourth quarter allocations.
Doc, thanks for staying with us till the end of this conversation, till the end of this edition of the program. I was going to take you to provisions being made or efforts you're putting into securing a DNA testing lab in Sierra Leone. That's a very significant aspect, not only for health, but also in the aspect of crime. In advanced countries, we see how this helps to solve crimes, whether it's for alleged sexual offenses or murder, whatever it is, but DNA labs do help. As we speak, we don't have that in Sierra Leone.
Yeah. Oh, thank you very much. I think, Vivian, what we're looking at is complete forensic capabilities, you know, and so it's not just DNA, because it looks like our pathologists here are still using
Old
a
school.
traditional old school thing. You know, I think with all of the newer technologies that are available to us, you know, we should be able to use molecular diagnostics to be able to help pinpoint crime. We have had a few attempts at establishing a forensic capability here through private sector. I think there was one group that came in and we were fine in negotiations, but they wanted us to make a commitment to pay guaranteed $20 million a year for the services. And I think that fell apart. I think we're looking at other alternatives. Again, it's not just Ministry of Health, but also the Ministry of Internal Affairs that's interested in this aspect. So over the next few weeks, months, you know, I think we'll revisit that and see. It's not very difficult to set it up, you know. It's more how do you maintain it. We could train people for it. How do you maintain it, and what's the fee for service? Because I think the molecular diagnostics is a little bit on the expensive side. So we will make that available. That's why we wanted to go to private sector. Let the private sector deal with that instead of the public sector. But there may be a middle ground where we could have a public-private partnership where government could provide the land, provide the infrastructure, provide staff. Somebody else brings the equipment and the reagents and stuff, and we have a partnership where they could provide those services. It's critical. It's really important. And I mean, as I see a Hands of Our Girls logo behind you, this is a very, very powerful tool that could have allow us to enforce the Hands of Our Girls policy.
I could remember a year ago, the ministry launched a pilot program or project at Connors Hospital, which is the electronic medical records system. Yeah. Has it proven?
Yes. So you know, people say there's a lot that's going on in these hospitals. Somebody, I think earlier on, they asked a question: where are the gloves and where? You know, we're bringing the highest number of push of supplies to the field. They used to give like 1 or 2 shipments a year. Now every quarter we have multiple truckloads of supplies that go into the facilities. The district facilities are supposed to redistribute it to the local facilities there. We have a challenge. That's why, you know, the thing that we work with ACC, at times some of these things land. A week later you go in, no gloves, no, pay for the gloves, pay for this. When the government has supplied this, the commodities to the facilities. So what we're trying to do now is to aggressively track from headquarters to the field, not only from the field, but also outside of the field to ensure that these commodities are being fully utilized and accounted for. So we have a new app that's been developed that's helping to pursue that, mHealth, that's helping to move that forward. On the electronic medical records, you know, this is 2024. Yeah? You cannot have a system where you go and you say, I am Fatmata Wuri, I was here 2 months ago, find my records, and they say, oh wait, let's go into the archives, and it'll take you 2 or 3 days to find Fatmata Wuri's record. It's very inefficient, it's really quite ancient. So what we're trying to do is to transition into a digital format such that you have a complete patient profile available to you in a complete medical record electronically.
So has it proven worthwhile?
So it's working extremely well at Connaught. We're looking to see how do you expand that to other locations. Again, this is a public-private partnership, and so we work with a private partner, a Sierra Leonean private partner, that's helping us expand this reach. We hope that in no time we'll be able to use this in all. It'll bring efficiency, it'll reduce corruption, it'll allow us to have a rapid turnaround, because you can now, you say, I name Mohammed Kamara 5 of number 2 Wallace Johnson Street, age 25. You're able to match all those paradigms and get an exact pull for you. And if you have your QR code and a profile, we're able to pull it up immediately. So the doctor has your records, has your information. We're also looking at an e-passport, health passport, that you could have that will have your QR code and your profile on it, such that it doesn't matter where you go, you will be able to read it and be able to provide your information for you. We're not piloting. We've gone past pilot in this country now. We're not piloting anything. We're a small country, 8.5 million people around the country. What we do is demonstrate. If the demonstration works well, we expand. And we do course correction as we expand.
Your earlier submissions paints a picture as if the sector is still handicapped in the area of adequate monitoring and evaluation of the facilities or perhaps the drugs that have been supported into the system. I was just reading through the websites of the ministry, wherein not too long ago WHO supported also the ministry with over 400 plus $1,000 US, medical supplies.
Yeah.
But it's as if it's still very hard to track where the supplies are and what's been done with those supplies.
So again, you cannot use old tools in this modern age to, I mean, the old tools are what we had. They're very inefficient, very ineffective. So what we're trying to do is to transition to an electronic system. You know, an electronic system allows you to not only receive and account for, but distribute and track. And that's what we're transitioning to. So you have a lot of monitoring and evaluation offices all over, but they have these tally cards, in and out cards and stock cards that they have. That's all yesterday. We're trying to completely move away from that and have an electronic system that's going to be able to help us out. We have some resources from the World Bank. We have some resources from Global Financial Facility. And we have very interested partners. And we have local entities that are helping us transition. I mean, you know of the Press Track tool that we just launched, I mean, a couple of months ago. The Press Track allows us to have every pregnant woman register her pregnancy with a complete profile of her. And our responsibility is to track that pregnancy from the first encounter all the way to labor and delivery and post-delivery. So I think electronic solutions, they're not a luxury. Right now, they're a requirement for what we want to do in the healthcare system.
Dr. Demby, we have a challenge with what we call it also reflects on your health. We seem to be a country that is, more on carbohydrate. Doctors would tell you it does have its own implications. There's Feed Salon. We know the ministry has a nutrition arm. In collaboration with the Ministry of Agriculture and other MDAs, what are you doing in that area of nutrition? Because it's very important. When the people get that, it also helps protect their health. Yeah. We don't seem to talk much or pay much attention to nutrition. Okay. What are you doing?
Yeah. So I think I'll maybe broaden the discussion a little bit more, because I think what has happened in this country over the years is people are equating health with hospitals. They go like, oh, you come to the hospital to take care of your ailments. But health actually starts at home. And what we need to do is to create a partnership with the community and ensure that the partnership empowers people to take care of their health. If you take care of your health, the need for a hospital is reduced considerably. Just take, for example, I saw AIV ran a story on stroke, and your colleague forwarded the story to me, Stroke is the end result of multiple failures down the road. Yeah. If you have high blood pressure that is not managed, it will result in stroke. What causes high blood pressure? High blood pressure is when you take too much salt, when you eat too much carbohydrate late in the day, when you don't exercise, when you don't take care of your health in general.
And rice is our staple food.
And so that's not a hospital medical thing. That is a home thing, because if we get that right, then you don't need to end up with a stroke at home, at the hospital. So you're right, we need to really focus on nutrition, on lifestyle issues, on ensuring, we work hard. We work hard, and our staple is rice. Rice is heavy carbohydrate. Yeah, if you eat heavy carbohydrate in the morning or at lunchtime, you're walking all day. You'll burn it. You burn it nicely. If you eat heavy carbohydrate at 10 o'clock or 8 o'clock at night, at 8:30 at night, you're not going anywhere. The carbohydrate sits there, it becomes fat, it becomes leading to your overweight. And if you overweight and you don't exercise and you have high salt intake, your blood pressure goes up, and the result of that is you get a stroke, you get kidney failures, you get all kinds of illnesses associated with it. So you're right, nutrition is really critical, but we need to expand beyond nutrition and individual health care as a prevention tool. So that's why we're looking at school health as a special case, because some of you don't old now, you can't teach an old dog new tricks, yeah? But you go to school and you say exercise. When you get PE at school, PE is so vital. It allows you to get the blood moving. It allows you to have your systems fully functional. Let's look at the food that we eat. Salt, this Maggi thing. Maggi is MSG. It's one of the most potent of the salts that gives you high blood pressure. Let's reduce the Maggi, although we can't do anything without Maggi these days, but we could reduce the salt intake. Let's exercise a bit. It's not running and whatever. I go to work every day at UU building. The lift is beginning to work now, but I don't use the lift. I run up the stairs. I go to a VP's office, you run up the stairs. You go to the State House, you run up the stairs. You exercise a little bit. It's not too vigorous exercise. Exercise a little bit. Put that in your routine. Honest to God, you reduce the need for the hospital. So again, let us take care of nutrition. Let's take care of some lifestyle issues for ourselves. And that way we'll contribute to our own health, our own well-being, and will reduce the need to use the hospitals.
As we gear up for the update in sports, Dr. Demby, would you say the country's statistics or ranking globally, more so in terms of maternal mortality, is it satisfactory as we speak?
Well, that's one of the things that every Sierra Leonean should be so proud of. Again, for us, our target is zero preventable maternal deaths in this country. That's our target. So this country had one of the highest maternal mortality rates in the world. It was about 1,300 per 100,000. I was in Myanmar, Burma. I was talking to the minister there multiple years ago, and he was like, "Where are you from?" I said, "I'm from Sierra Leone." He said, "Sierra Leone, I know Sierra Leone, I think Sierra Leone and Burma used to be at the bottom of the pile, But over the years, we've done a lot to be able to reduce this. When I came in, it had dropped from 1,700 to about 717 per 100,000 live births. What we did was we said, look, over the next 3 years, we're going to drop it to below 300 per 100,000 live births. Last year, it was announced that it's dropped to 443 per 100,000 live births. Right now, we're waiting for the official announcement, but it's dropped below our targets we set. And what we said is we're not going to glide to 2030. We're going to have a major inflection that will change the narrative and drop maternal mortality to less than 70 per 100,000 by 2030. And so it's the critical tools that we're putting in place. This press track, this tool that's allowing us to identify every pregnant woman and be with that pregnancy and do everything to assure the safe delivery of that pregnancy is a major tool in our hands. The obstetric care that we have, basic obstetric care and comprehensive obstetric care, is a major tool that we have. The training of OBGYN specialists now, as you saw, we just graduated 10 of them now that are senior specialists in the West African College of Surgeons. That's contributing to that. We have midwifery schools in the next couple of weeks, actually opening a brand new midwifery school in Kenema. Again, all of these are tools that we're using to double down and bend the curve and reduce maternal mortality to less than 70 per 100,000 by 2030. When we say these things, people are like, two camps. One camp is, you crazy? It's not possible. People move 10 points in 10 years. Another camp says, that is the ambition that we want to see. That is the ambition that we want to see. And we look for the latter. As I speak, yesterday, my colleague minister from Burkina Faso is sending a team here to come and look at how we're doing it. As I was saying, the Minister of Health of Botswana is sending a team to come and see how we're doing it. One of the things I'm really worried about is some of these things we're doing are so foundational, but we're not bragging enough. We're not telling the public enough to let them know what's going on. It's other people outside of the country that are really admiring us and what we've been able to accomplish. The drop in maternal mortality, it's not even close. It's the fastest in the whole wide world. And people are saying, how did you guys do it? Again, that's why now with the bio we doctor them, now with bio we nurse them, they're doing a phenomenal work, but it's not just the medical staff. The community themselves, the paramount chiefs, the traditional leaders, the community health care workers, we combine and co-own every pregnancy and ensure that we influence the outcome of that pregnancy. We're not going to be satisfied till we have zero preventable maternal deaths in this country.
It's mostly said that a beggar has no choice. But have we choices in terms of the drugs that have been donated in Sierra Leone? In other words, have we devised mechanisms? Do we normally check the drugs that have been?
Yes.
That have been.
That's a simple answer. Yes. That's a simple answer. Yes. But again, I think there's a slightly different attitude. What's going on is it's not visible to everybody, but there's a slightly different attitude in our relationship with our partners. What happened in the past is the partners will come in and tell you what they want to do, and tell you what they want to give you, and tell you why they want to give you this. We're changing that. And what we've done is bring our partners together and build a vision for the country. They say, if you don't have a plan, they have a plan for you. We have a plan now. We have a clear vision. So my engagement with our partners is what we call the 3 A's. 3 A's. Number 1A, we have a clear vision. Our partner's role is to accompany us as we achieve this vision. Accompaniment means you're with us, you're supporting us, you're there, you listen to us, you encourage us, but you don't tell us what to do, you accompany us as we go for this vision. The second A is alignment. We cannot say this is where we're going and you're going in separate directions. You have to be aligned with what we're doing. The third A is accelerated pace. We're in a hurry. We're in a hurry if we want to be able to make the kinds of impact we're making. We want our partners to accompany us, to be aligned with us, and to have an accelerated pace. And I haven't heard any no from the partners. They say we want to work with you.
Dr. Demby, we're rounding off now in maybe a minute or less. Your closing curtsies.
This has been a great opportunity to catch up with you all and catch up with the nation. 2 quick things. First, yesterday I spoke to our colleagues in Rwanda. We have 20 Sierra Leoneans who are deployed in Rwanda to help them contain the Marburg outbreak out there. I mean, these are the best Sierra Leoneans. We're so proud of them. The country is so thrilled that they're there helping with the containment of the outbreak there. Secondly, this is a very, very proud moment for Sierra Leone because we have the National Rehabilitation Center in this country. You know that prosthesis, when people have lost their limbs, their legs, their arms, traditionally we have these old wooden attractions and crutches that we give them. Now this is 2024. This is the modern era. The president has negotiated with MIT, Massachusetts Institute of Technology, the greatest technology institution in the world, to partner with us in building capabilities and capacities here in Sierra Leone with smart prosthesis. Smart prosthesis allows you to have electronic connection with nerves to be able to make limbs that are near natural And it's not only that, they have CT scans and things that will make custom-made prosthesis for people. They will not only do the design of it here, they will manufacture it here. So we're building a new factory here with Sierra Leonean technicians, with Sierra Leonean clinicians who will help not only custom fit these electronic devices, but also utilize them and manage them for our people. So again, we're very, very pleased that in the next week, I think the 7th of November, we're going to have the first graduates from this program who will have their white coat ceremony, and people from Massachusetts, MIT are coming in, the leadership in the government of Sierra Leone will be there. This is a big solution for amputees and people who have limb issues here. We're not only making smart limbs here, we're not only fabricating them here, we're designing them here by Sierra Leoneans for our people. We've invested about $24 million to rehabilitate the facility. A lot of the equipment is here now, more is on the high seas. We have a problem though. There are lots of squatters who've gone out there and occupied the land, and we've been talking then to them for the past few months to let them to clear up this and let us really fully utilize this facility. People have put their wear on the road. You can't access it. They're harassing people who go up to the road. So over the next few days, we're going to clear these people and allow this important facility to be able to serve Sierra Leone best. Guinea, Liberia, Ghana, even Nigeria, they're wooing these people to go to their countries to set up shop there. They said they want to come to Sierra Leone because the need in Sierra Leone and our history after the war is so profound that they want to be able to help us. So let us help ourselves. And so all those market people who are encroaching on this facility, this is the time to give us the chance. This is the time to give these amputees the opportunity to have state-of-the-art technology.
Thank you so much.
You know that Blade Runner?
I'm so sorry to interrupt you.
I know, you know the Blade Runner?
Sure. Our time's up.
Those are the things that they're going to provide for people. Thank you very much.
Thank you so very much, Dr. Demby.